to be with us tonight. Um, my name is James Hayden. I work for Boston Scientific, and our speaker tonight is Dave Fenig, who is been with Chesapeake Urology for more than 10 years. He is the director of male fertility, microsurgery, and sexual health for the practice. In terms of education, he did his residency at NYU and then did a fellowship focused on andrology at Baylor College of Medicine. So a lot of the things that he does day to day, he's been honing those skills since that fellowship at Baylor. I just, a little housekeeping. We're going to answer all the questions at the end, but if you go into your little chat box at the bottom, you can ask your questions real time. So please, when they do come to mind, go ahead and put them in there. And then Dr. Fenig will address all the questions at the end of the presentation. So we have a slide deck first and then Q&A at the end. So once again, thank you for joining us. And I'm going to throw it over to you, Dr. Fenig.
Great. Thanks, James. Good evening, everyone. Thanks for attending. Tonight, we're going to talk about the signs, symptoms, and treatment options for erectile dysfunction. We'll talk about what is it, who has it, what causes it, and then obviously the treatment options. So what is erectile dysfunction? It's defined as the persistent inability to achieve or maintain an erection firm enough to have sexual intercourse. It's very prevalent. Approximately 1 in 5 American men over 20 years old experience ED in their lifetime. And estimated more than half of men over 40 have some degree of ED. It affects approximately 39 million American men. So this is the erection process. When a man is aroused, the nerves surrounding the penis become active. The muscles around the arteries then relax and more blood flows into the penis. The additional blood makes the penis erect, and the harder it gets, the veins get compressed to the side in order to keep the blood in the penis and stay erect. Some patients have what's called a venous leak, where the veins do not compress well and the blood leaks right out, resulting in flaccidity. This pie chart shows the causes and comorbidities associated with erectile dysfunction. When I talk to patients, I tell them that these are the main causes of erectile dysfunction. One, vasculogenic, meaning blood vessel related disease. Some people have low testosterone. Some people have neurogenic ED from spinal cord injury or even related to neuropathy from diabetes. There are medication related things, and a not well talked about cause might be obstructive sleep apnea that's undiagnosed, and then there's more psychogenic situational factors. So the top 3 physical causes are vascular causes or blood vessel related causes, diabetes, and medications. Now, erectile dysfunction can be a result of prostate cancer treatment, and it can be a result of or a precursor to diabetes and heart disease. Let's talk first about erectile dysfunction and diabetes. Now, according to the 2012 census data, 15.5 million men in the US have diabetes. Approximately 1 in 2 men with diabetes have sexual troubles caused by their disease. In men with diabetes, ED is more severe and associated with a poorer quality of life. In my practice, the majority of patients I see with severe ED are diabetic. ED can occur 10 to 15 years earlier in men with diabetes, and it's less responsive to oral treatment than patients without diabetes. And in some patients, ED can be the presenting symptom of diabetes even before it's diagnosed. So diabetes and related conditions can damage the nerves and tissues associated with achieving and maintaining erection. 60 to 70% of people with diabetes have nerve damage, also called neuropathy. Diabetes also accelerates the process of what we term endothelial dysfunction. So the endothelial layer of the blood vessels is the inner layer. So this is the layer that can dilate, allow blood in, and also constrict to control blood flow. Now, oral medications not only require sexual stimulation in order for the nerves to signal the blood flow in the endothelium. And if damaged from diabetes, pills won't be as effective. So factors that may increase ED in men with diabetes include age, the duration of diabetes, the poor glycemic control. I often ask men what their hemoglobin A1C is to ensure that their glycemic control is fine. Their presence of microvascular complications. Diabetes affects nerves and blood vessels, and is also associated with heart disease, as we'll see later. So men with diabetes are at higher risk for heart disease. Diabetes and heart disease can increase the likelihood of experience erectile dysfunction. Having diabetes nearly doubles the risk for heart attack or death from heart disease. So we can see that ED can predate both diabetes and heart disease, and we'll touch on the heart disease in a second. But men with diabetes and ED may develop coronary artery disease 2 to 3 years after the impotence, and may also experience a major adverse cardiovascular event later. So again, let's touch on the heart disease issue, because ED really may be a warning sign of more serious issues to come. ED can predate heart disease by 2 to 3 years and major adverse cardiovascular events by 3 to 5 years. And so I talk to all my patients who come in with erectile dysfunction that ED can predate heart disease. Go talk to your primary care physician, get a full workup, get an EKG, and make sure the heart's okay. Because a middle-aged man with no other comorbidities, who we don't think is from a psychogenic cause, this could be the main indicator of future heart disease. So the reason this is so is if you look at this, the size of the arteries, the penile artery is about half the diameter of the arteries supplying blood to the heart, or the coronary blood vessels. So if you have atherosclerosis or plaque in the penile arteries, in the blood vessels to the heart, you will also have it in the penile arteries. And in addition, the penile arteries may become affected more or sooner than the heart blood vessels. So you may reduce your risk of ED by improving heart health. So that includes diet, exercise or physical activity or aerobic activity, weight loss, quitting smoking, and reducing stress. Let's touch on low testosterone for a second. So low testosterone is also called hypogonadism, and this occurs when a man's body produces less testosterone than normal. The decreases in testosterone may increase the risk of sexual dysfunction or general feelings of well-being. Approximately 4 in 10 men over the age of 45 may have low testosterone, and it is more common in men who are obese, have diabetes, high cholesterol, or high blood pressure. So some symptoms and signs of low testosterone include low energy, low sex drive, problems with mood, memory, concentration, as well as erectile dysfunction. Now, what I will say here is that there are men that are diagnosed with low testosterone as a result of a workup for erectile dysfunction. However, not all men need to be treated for low testosterone. Men generally with good energy, good sex drive, probably should just be treated for the erectile dysfunction and not the low testosterone. In a man with low energy, low libido, and the other symptoms, certainly treatment with testosterone may improve the erectile function. So let's talk a bit about erectile dysfunction and prostate cancer treatment. There are nerves around the prostate that provide stimulation for an erection, and these may be stretched or injured during prostate surgery or even radiation. The treatments can affect a man's ability to get an erection on a temporary or even permanent basis. What we see in surgery is that the nerves can be stretched as the prostate is removed. And with radiation, being that the nerves are adherent to the prostate, there is some radiation damage to these nerves. Now, the rates of sexual dysfunction reported in the literature vary widely after prostate cancer treatment. In some studies after radical prostatectomy, they estimate 10 to 46% of men 1 year after surgery had erectile dysfunction. I would say that a conservative estimate is about 50%. I would certainly say that there are some people that just don't want to publish bad results, and that's why their potency rates are inflated for post-prostatectomy. Now, erectile dysfunction can also be affected after radiation, which can occur in up to 50% of men. Now, it's a little different in that after radiation, could be 2 to 3 years down the road that you see changes in erectile function, whereas after prostate cancer surgery, typically the erections are minimal up front, but then over the course of a year or even two, the erectile function may improve. I'll also touch on Peyronie's disease. Some may have heard of it. It's a disease or a development where people get scar tissue on the penis. This fibrous scar tissue is also known as a plaque, and this can cause curvature of the penis, shortening, as well as even painful erections. This can complicate the ability to have sexual intercourse, and it can also affect the ability to get an erection. There are obvious psychosocial stressors as well. Now, Peyronie's disease may appear suddenly or develop gradually. Again, there are scar tissue or plaques that can be felt under the skin and cause the penis to bend and shorten, and erections may be impacted by the development of the scar tissue itself. Now let's focus on treatment options for erectile dysfunction. That's why we're all here. There are basically 5 main treatment options. One are pills, oral medications. There are injections, intracavernosally, penile implants, vacuum erection devices, and urethral suppositories. So oral medications work. They require stimulation, first of all, and then they increase blood flow to the penis with stimulation, and that will improve erections. Again, requires sexual stimulation, and depending on the pill, that will tell you when to take it, but typically Viagra an hour or 2 before sexual activity on an empty stomach. Cialis you can take farther in advance, probably up to 24 hours in advance. They can be effective in 50 to 85% of cases. What we would say is that, as we touched on earlier, men with severe heart disease, coronary artery disease, or diabetics, pills will be less effective and often don't work. Almost half of men with ED after prostate surgery have the pills stop working or not working at all. And again, as I mentioned, diabetics are more likely to move on to other treatments. Side effects of oral medications include headaches, nasal congestion, flushing of the face, even backaches, muscle aches, heartburn. Always talk to your doctor if sex is inadvisable because of cardiovascular status or recent heart attack. There are cautions with alpha blockers for BPH. Patients just should be stable on their alpha blocker before using the medications, and pills can't be used with patients on nitrates, nitroglycerin for chest pain. This will cause a dangerous drop in blood pressure. Now, the vacuum erection device is basically a cylinder. It's a plastic cylinder that goes over the penis. It's basically pumped manually or battery powered, and it creates a suction which draws blood into the penis, stretches the penis, and once the erection is achieved, you can place a constriction ring around the base of the penis. What I would say is that satisfaction rates here are 68 to 80%, which seems even a little high to me. what does seem normal is that 86% of patients decide to move on to other treatments. In my experience, patients typically complain of that the penis feels a little bit cold. It's not totally like a real erection. It's definitely cumbersome and a little unromantic. There can be some bruising and penile discomfort as well. Now, the urethral suppository muse is used by inserting this applicator into the urethra, which deposits a pellet in the urethra, causing blood vessels to dilate and blood flow into the penis and pelvis. Now, most men don't use this long term, and many men have significant complications from it. The most common side effect is not only the pain from insertion of the applicator, but severe pelvic pain from the engorgement and flow of blood to the pelvis. Now, intracavernosal injections. So these are shots into the shaft of the penis. This is something that will work within 15 minutes of onset of injection, excuse me, if it does work. I often stratify patients by doing what's called a penile Doppler ultrasound. And this is basically an ultrasound where we inject medication into the penis to dilate the blood vessels and see what the flow is like through the arteries and veins. It tells us not only the flow data, but also whether there's any curvature to the penis, as well as does the medication work. If a patient has a venous leak, as I said before, even injections won't work and patients will move on to penile implant. So in terms of effectiveness, it really depends who your patient population is. Approximately 60% of patients were satisfied and continued use in one study. However, long-term, only about 20% continue the therapy. And again, in patients with diabetes, oftentimes this doesn't work. The most common side effects are, excuse me, penile pain, scarring of the penis, which can lead to Peyronie's disease, which is the curvature and shortening that I talked about earlier. It can cause priapism, or those prolonged 6-hour erections you hear about. They can be quite painful, and patients can end up in the emergency room. So when this medication is not used correctly, these things can happen. And the reasons for discontinuation are typically either doesn't work, patients have pain, or they just don't like the injections. Excuse me. So let's talk about penile implant. So the penile implant that is most commonly used consists of 3 pieces. So there's a right and left side of the penis, the corpus cavernosum, and then there are 2 cylinders basically that go in the right and the left of the penis. There's a pump that sits in the scrotum, and then there's a reservoir of saline that's placed in the pelvis or lower abdomen. So essentially, it's a hydraulic system. So you pump the pump that's sitting in the scrotum, and the fluid moves from the reservoir into the cylinders, takes about 10 to 20 pumps, and then the cylinders inflate and they become rigid. And patients are always surprised at how rigid they actually do get and how lifelike it feels. And we'll go on the show later, but patients and partners are extremely satisfied with this. Now, everything is self-contained. You won't see anything outside the body. The only person that's going to notice this besides the man with the implant is the partner, who may notice basically another object in the scrotum, basically like a third testicle. So how effective is it? 98% of patients report erections to be excellent or satisfactory. At 7 years, 94% are still in use and free of revision. There are some side effects. Pain is typically short-lived. There are some mechanical malfunctions that can occur. Infection is something that we worry about. It is more common in diabetics. I do often counsel my patients to get their hemoglobin A1C as tight as possible in order to decrease the risk of infection. So the benefits of the penile implant is designed as a permanent solution to ED. It's spontaneous. You can have sex whenever you want with just a quick pump. The erection can last as long as you desire. It's entirely contained within the body. There's high patient and partner satisfaction rates. It doesn't interfere with sensation, ejaculation, or orgasm. They've been around since the 1970s. Nearly 500,000 patients have been treated with a penile implant. I will mention there is going to be a little video at the end describing what I showed in this slide here. So just stick around, and I just don't have it in my slide set. So again, penile implants, they are a surgical procedure. There's always risk to surgery. Penile implant is meant to be permanent. You cannot use pills after or injections or anything like that. The implant's meant to be there and to be used. There may be mechanical failure. As I showed in the slide before, the mechanical failure rates are low over the course of 7 years, probably about 6%. There are, if the implant needs to be removed and replaced due to infection, the penis may become shorter or more scarred. Pain is typically short-lived again, and there are some patients, such as men with spinal cord injuries without sensation of the penis, who may be at increased risk of having issues. Now, there are a couple implants that I may have skipped over, and perhaps a slide is missing. But I will say, so there are actually 3 implants. There is a 3-piece, which is what I've shown here. There's a 2-piece known as an ambicure. This is basically just a cylinder and a pump, and the fluid is in the back of the cylinder. The ambicure typically is used for patients with major pelvic surgery. However, satisfaction rates aren't quite as high as the 3-piece. Now, there is something called the Spectra, which is just basically a semi-rigid prosthesis that bends up and down. It's most commonly used in men with spinal cord injury. I would say the downside of the semi-rigid or malleable implant is that it's not totally concealable. There'll always be a small bulge in the pants. So the 3-piece is the way to go if it can be done. It will, when it's totally deflated, nobody can see it because it's completely flaccid. And that's about that, but I'll certainly answer any questions you have about the other devices as well. So in summary, ED is a common problem and may be associated with other conditions. There are a variety of treatment options. Penile implants can offer a permanent solution. And so talk to your partner, talk to your ED specialist, or a prosthetic urologist, such as myself and others, or find one at edcure.org. That's about all I have to say. So I see some questions on the side. So in terms of, I see a question about medications. I'm assuming you're referring to the ED medications, and those would be things like Viagra, Cialis, Stendra, Levitra. In terms of what level is considered low, I am not sure what that is referring to. And prostate surgery not related to cancer, this is a good question. So there are other prostate surgeries such as TURPs, transurethral resection of the prostate for BPH. Also, simple or suprapubic prostatectomies for for very large prostates, and some of these procedures can cause some ED, and that is true. Most often, though, these causes are not very significant. Somebody asks, my A1C is 6. At age 80, is that a risk for ED? That seems to me to be acceptable, although I'm not a diabetes specialist. Let's see, I'm 24-year-old. What can be causing my weak erections? Well, most often in a young man who's not diabetic, the overwhelming cause of erectile dysfunction in a young man would be more psychogenic, could be situational factors, psychological stress, long work schedule, stressful work, lots of different causes. Premature ejaculation also can be due to stress and anxiety, can be lifelong in certain patients, and other questions. Again, I'm not a diabetes specialist, so I can't say what hemoglobin A1C is less troublesome, but there was a study for penile implants about having A1C less than 7.5 and in order to reduce the risk of infection. And that's basically what I talk to my patients about. Are penile implants covered by insurance? Overwhelmingly, yes. And I would talk to the reps about that. I know there was a slide that, which again, I don't
Do you
see.
want me
Sorry.
Do you want me to do the animation, Dr. Fenig? I'm sorry.
Sure.
Okay.
James, while you're on, you want to answer the question about insurance coverage?
Sure. So yeah, so penile implants are covered by Medicare. They're also covered by most private insurances. Both Dr. Fenig's practice, Chesapeake Urology, and Boston Scientific do run insurance checks pre-surgery, so you will know if you have coverage before you actually go in for your procedure. But the vast majority of cases are covered, and just sometimes employers, depending on what plan you have with your employer, might exclude it. But again, the vast majority are covered by insurance with a little bit of out-of-pocket cost.
Yeah, I would add, in my experience, medical assistance, unfortunately, typically does not cover penile implants, although I believe there is one policy that does. So I'll move on to a couple other questions. In terms of losing natural size from the implant, well, so there is a 700 LGX, which is a length girth expansion, and a 700 CX, which is just girth expansion, which may be a little wider. So I think those of us who do a lot of implants, assess our patients and look at penile size, and certainly that's one benefit to doing a penile ultrasound, and then we pick the right implant. Now, in terms of losing length, there will be some penile shortening from an implant. You can't really replicate what Mother Nature gave you. Certainly the head of the penis or the glands, when it engorges, it kind of bulges out, and the cylinders or the corpora of the penis are kind of within that glands, and so it kind of pushes the glands out. So I think that limits some of the natural length, although the LGX, which is the length girth expansion, does lengthen the penis somewhat. Now, if somebody asked about light treatment, you're probably talking about energy wave therapy or shockwave therapy. This treatment was really studied in Europe, and basically it involves ultrasound waves to the penis. You know, it has limitations. First of all, the limitations are, who's it going to work for? Primarily, the patients I see it working for are the patients with the most mild ED, who are on the minimal amount of medications, and they may sometimes not need the medication when they do it. However, what we're seeing is that a lot of patients a year later need additional treatments, and it happens to be very costly. And so it's not a treatment option for everybody. In terms of herbs and other natural remedies, I am not an expert in herbs and other natural remedies, so I will leave that to others. And then in terms of the risk, the relationship between BPH and ED, there really isn't a direct correlation. Now, in terms of somebody asked about testosterone level low, the Endocrine Society guidelines are less than 300, but I will caution you that testosterone's on a bell-shaped curve. So there are many men that feel fine less than 300, and there are some men that don't feel well when they're a little bit over 300. So not everybody needs to be treated. If someone has good energy, good sex drive, and pretty mildly low testosterone, I would say just treat the ED. So the saline solution gets put into the reservoir at the time of surgery. So the reservoir is always full. And so it is a self-contained system. Let's see. So somebody asked about 5 milligrams daily of Cialis. Yes, it can be used for patients with ED and lower urinary tract symptoms. So it may help urinary flow as well as ED. And somebody asked about having an artificial urinary sphincter. Is this a problem? It is not a problem to get a penile implant with an artificial urinary sphincter in place. Many are placed at the same time, and even if they're not, it's fine. Patients get used to having hardware in their scrotum. They have a pump for the AUS on one side of the scrotum and a pump for the penile implant on the other side of the scrotum. So in terms of somebody asked about Cialis prescription, well, you can take up to 20 milligrams, not more than every 2 to 3 days. Surgery, surgery times vary. I would say, about 60 to 90 minutes. In our practice, we typically do it as an outpatient in a surgery center. We find that there are less infections and things move more quickly, having a dedicated team of nurses and assistants who do this a lot. The only patients that we really do in the hospital are if it's mandated by their insurance or if patients can't be cleared for general anesthesia in a surgery center. Let's see. So the penile implant, I believe the only area in the implant that might be any part metal or something similar would be in the pump, which that is the case, but they don't cause problems with MRIs or security checks or anything. Retrograde ejaculation will not factor in with the implants. If you have retrograde ejaculation, the implant will still work. You'll have normal skin sensation, you'll have a normal orgasm, and you just will ejaculate backwards. And for those of us for those who don't know, that can be seen in patients with diabetes or who've had procedures for BPH. And you can get the implant if you have Peyronie's disease. Depending on the degree of curvature, it may require a procedure for both the Peyronie's disease and the ED at the same time. So sometimes we do what's called modeling, where we put a penile implant in a patient with mild curvature, and we try to straighten the penis manually. However, there are some patients who have real significant curvature that may need additional procedures to straighten out the penis. Any other questions regarding the ED or the implant? James, are you on there?
I sure am. Thank you so much for your time, Dr. Fenig.
Sure.
I can't think of many other questions to cover. I think everyone else's questions covered everything. So if you don't have anything else to add, I'd like to say, make sure to call Chesapeake Urology to get an appointment with Dr. Fenig. He practices he does his clinic out of the Maple Lawn office. And then he'll do procedures both in Silver Spring and Columbia, depending on which procedure. But you can call. Are you still doing telemedicine, Dr. Fenig?
Sure, I do telehealth consults as well.
Great. So they can call the same number, I think, to schedule either a telehealth or in-person visit. So I would encourage everyone to do that. Then Dr. Fenig can kind of address on a more personal basis any problems you might be having. But other than that, if you don't have anything else to add, Dr. Fenig, I think we can wrap up.
Now, thank you all for coming and allowing me to present to you tonight. I look forward to hearing from you and seeing you.